Hello, and welcome to Direct Supply's Continuing Education webinar series. Direct Supply offers monthly webinars on a variety of topics throughout the year. The topic for today is choosing the right back support in the long-term care setting. My name is Robin Malik, and I will be facilitating today's meeting. Please note, the information contained in this presentation is intended to provide general information but not advice about certain regulations and initiatives. This is not intended as legal or other advice, and each situation may vary depending on the particular facts and circumstances. You should not act upon this information without consulting with qualified legal counsel. Today's webinar will be presented by Endsjo. Anna is an occupational therapist with a Master's of Occupational Therapy degree from Nova Southeastern University and a Bachelor of Nutrition and Dietetics degree from the University of Delaware. Anna has worked as an occupational therapist for over 15 years, mainly with the geriatric population in a variety of treatment settings, including acute care, subacute care, outpatient, acute rehab, long-term care, and as a lymphedema certified therapist. Over the last 9 years, she's been dedicated to the betterment of the treatment of elderly in LTC centers. Her time was focused on seating and positioning and contracture management of the nursing home residents. Through this experience, her hope is to guide other therapists, rehab directors, nurses, and administrators through blogs, webinars, and live courses to be able to do the same. And now, please welcome Anna.
Hello, everyone. Thank you, Robin, for that introduction. I'm excited to be with you today and to present to you the course titled Choosing the Appropriate Back Support in a Long-Term Care Setting. So today's goals and objectives are that, number one, I would like for you to be able to list 3 goals when utilizing a specialized back support. Number 2, list 2 back support shapes and a benefit and consideration for each one. And then lastly, I want you to be able to name 2 spinal abnormalities that warrant the use of an adjustable back support to assist in achieving maximum stability and even pressure distribution. So seating and positioning has come a long way through the years, and we have really developed knowing that just a wheelchair cushion is not enough if you want to strive for an optimal position for your resident. However, there is this little myth out there that we still have to clear up with some newer therapists or some therapists that just haven't had the opportunity to take as many seating and positioning CEUs, and that is that new cushions do not solve all seating issues. And I know from experience, and I hate to admit that, but it's true, but when I first started with seating and positioning, I would get a referral come across my desk, and the first thing that my eyes would be drawn to is the cushion. And I think to myself, what cushion are they on, and what cushion can I replace that with? And I oftentimes thought to myself, if I just replace that cushion, then I can stop the pain in sitting. If I just replace that cushion, I can prevent or help to heal an existing pressure injury. If I just replace that cushion, I can prevent falls or injury from the wheelchair level. But the cushion is just not enough. It is a good starting point. We should always start with the pelvis, but it should not be your ending point as well. So a lot of times we think of that saying, that question, what came first, the chicken or the egg? And we can relate that to seating and positioning just as well. And we have to ask ourselves, what came first? Did the spinal abnormality that the patient is presenting with change what is going on at the pelvis, or is something that's going on at the pelvis change the postural abnormality, change the spinal curvature? And really, the answer is most likely they were very much so linked. And so we'll never be able to correct one without addressing the other. Another thing that we're certain of is that we need to start considering much more than just the pelvis and much more than just the cushion. And we're all therapists, or we're nurses, or someone in the healthcare field, and we know that you look at the pelvis and not think it's going to change what's going on at the trunk and at the spine. So we need to really consider more than the cushion. We need to start looking at specialized back supports and the appropriate wheelchair models if we really do want to stop the wounds, we want to stop people falling from chairs, and a lot of the other health complications that come from poor wheelchair posture. So new cushions cannot solve all seating issues. And we need to keep in mind that the pelvis does not work alone. And I pretty much just touched on that. And good wheelchair posture alignment is impacted all the way from the head and the neck down to the foot and the ankle. Secondly, we have to understand this idea that you can go out and you can buy the best cushion on the market, but that best cushion can lose all of its effectiveness if not used in combination with the appropriate back support and the appropriate wheelchair model. So one thing we have in a lot of our long-term care facilities is we have wheelchair models that are set at 90 degrees. So here's my wheelchair. This is the back support and this is the seat support. And they're set at a fixed 90 degrees. Well, what happens is we're dealing with a geriatric population that has changed for many reasons, and we'll kind of go into those reasons in a moment, but they can't even get to 90 degrees at their hips. So there's no way that they're going to be able to sit well in a chair that's forcing them to sit in a posture that they can't get to or they can't tolerate for long periods of time. So what happens is the patient starts to slide down or they start to lean over or slump forward. And so what happens is back here where the pelvis is supposed to be, it can't get there. So the patient starts to sit halfway up the wheelchair cushion, halfway up the wheelchair seat, and the cushion is designed for the pelvis to be back here, but the person's pelvis is over here because we're trying to force them in an angle of a chair that they can't tolerate. So that cushion can't even do its job, and a lot of times we buy this fantastic $300 cushion and then we think, well, this didn't do what it said it was supposed to do. It's not the cushion, it's everything else. It's the configuration of chair, the fact that we don't have any of the pressure going onto the back support and we're not contouring to the spine to stabilize it that can then stabilize the pelvis. And then lastly, a back support is just as critical in a seating system as the cushion. And I know I'm going to say something very drastic right now, and a lot of you are going to raise an eyebrow, but I really truly feel that every cushion that walks out the door, a back support should go with it. I'm not saying the most expensive back support on the market, but again, we can't be addressing the pelvis and leave the spine alone and think the pelvis is miraculously going to be fixed. We have to address both the pelvis and the spine if we want to prevent any injuries and we want optimal seating systems. So when I'm a mentor to older therapists that are trying to, let me not say older, more experienced therapists with more years under their belt that just haven't really been dabbling in seating and positioning, and I also get new students coming in, I always tell them, if you just think of the simple equation with every referral you get for seating and positioning, and you consider these three pieces every time, you're going to end up with an optimal seating system. And the first thing is we need to look at the cushion style. Should they be on a general use cushion? Should they be on a skin protection cushion? Or should they be on a skin protection and positioning cushion? If we then move up the body to the back support and we take off that sling back that can hammock and is not going to provide the support that we need, and we replace it with something that can provide the stability and the pressure distribution that is needed, and we couple that lastly with the appropriate model wheelchair that we can play with back angle, we can raise seat to floor height, we can raise armrest height, then we'll be able to configure the back and the cushion the way it's supposed to and end up with that optimal seating system. And with that, together, the cushion, the back, plus the appropriate wheelchair model will be able to allow for maximum contact with the seat and the back surface to achieve postural stability, to prevent the leaning and the slumping and the sliding down. We'll be able to allow for even pressure distribution so that we're distributing pressure over the greatest surface area and decreasing pressure going into a small area that would then cause a wound. And we'll be able to attain and maintain that postural alignment for hours on end, from 6 a.m. in the morning till 6 p.m. in the afternoon when that person lays back down. So in order to understand the importance of a back support, we need to know what's going on at the spine, what is changing, and so we have to start with what does an ideal spine look like. So this is a little bit of an anatomy refresher. And an ideal spine should be balanced and upright. So as of right now, I was not sitting with an ideal spine, but it should be balanced and upright. You should see no rotation, so none of the vertebrae should be twisted in any way. You should probably see no lateral curvature, so you shouldn't see any type of scoliosis. You will see normal lordosis in both the cervical and the lumbar spine. We are not flat. We have natural curvature. And you should see a normal kyphosis in the thoracic spine. And so when you look at someone from the lateral view, just like we are on this slide, you should see a very nice desired S shape. And then you know that that person has an ideal spine. But what happens if something is off? And this is what we usually see in our geriatric population in our setting. So we start to see these abnormal postures, and we as therapists and as nurses, administrators, anyone working in the nursing home should be able to pick up on these, screen them, and then do something about it. So the first spinal abnormality that we probably see is a kyphosis. And this is, like I said, the most commonly seen one. And we normally it's like a dead giveaway because we see that C shape in the thoracic spine. And in very, layman's term, it's almost like a hunchback, right? You just see that person with a very, very, very C shape at the thoracic spine. The head goes down and kind of looks down at the ground or at their lap. The next postural abnormality of the spine would be a lordosis. And what happens is the pelvis actually goes into an anterior pelvic tilt, and it pushes that pelvis forward. And as you can see me doing that, you can see my back hyperextending. And what oftentimes we see in our nursing home settings is we see this with very obese patients. Someone who has a lot of residual tissue in their gluteal area, and that gluteal area makes contact first with the back and pushes the person forward. Well, what the person wants to do is they want their back to hit the back support, so they'll then hyperextend over their excess adipose tissue and try to make contact. And it develops this excessive lumbar lordosis, which is what we know in layman's term as a sway back. And then the next abnormal posture of the spine is the scoliosis. And this is often happening because we have some type of hip hike. And so one side of our hip is a little bit higher or lower on one side. And you can see that right here in this presentation, that one side of the pelvis is lower. So what happens is, as one side of the pelvis is lower, it causes me to lean to one side. And due to the writing reactions that we naturally have, and I want everyone to try to do this with me, in order to kind of lean like the Leaning Tower of Pisa, you actually have to tighten your trunk muscles in order to lean and stay lean. But what happens naturally if you kind of relax and then you lean, your body actually tries to come back to midline. That is our normal writing reaction. So as the pelvis goes lower on one side, you'll lean that way, and then your spine and your head and your neck actually want to come back to midline. And that forms that scoliosis. And it's very commonly seen from the posterior view. You will see an S shape at the back. Don't confuse that with the lateral view that we saw in the ideal spine, where you see a nice desired S shape from the lateral view. But if you then look at the person from the back and you see an S shape, then you know that you're dealing with a scoliosis. The last spinal abnormality that we should be screening for and doing something about is the spinal rotation. And this is a dead giveaway because usually the person is in a wheelchair that might be too small, or they have a leg length discrepancy. And so what happens is they kind of twist in their chair, and you'll see one of the shoulders coming out towards you, and the other shoulder is making contact with the back. So you see this rotation, this kind of twisting look to the patient. So each one of these spinal abnormalities, as I said, is linked to a pelvic abnormality. And what came first, the chicken or the egg question again, right? So again, it's not that one completely caused the other, but one may have been more obvious and really started the other one to be more pronounced, or vice versa. So the posterior pelvic tilt is usually linked to that C kyphotic posture of the spine. And what's going on is we have some bony landmarks, and how you can kind of palpate for this is if you have your patient, you can look for those really those bones that kind of jut out at the front of your pelvis, which is what in layman's terms are called as our hip bones. The time when your little girl or little boy is kind of making this motion and they put their hands on their hips, those bones that your hands lie on are your Oh, sorry, someone just told me that they lost connection. Can you guys still hear me at DS?
Yep, we can.
Okay, I just had a message come up. So you put your hands on your hips. I think that's a song, put your hands on your hips. And so when you feel those two bones that jut out, those are your anterior superior iliac spine. In short term, ASIS. And then if you go to your lower back, right where your back hits the top of your bottom, you'll feel those dimples in your back. Those are your posterior superior iliac spines, which is also known as your PSIS. So when you're dealing with a posterior pelvic tilt, what happens is your pelvis tilts backwards, and those dimples are lower than the hip bones in the front. So you're dealing with a posterior pelvic tilt. And why is that bad for us? Why should we know that? This produces in what we probably know as a sacral sit. And what happens is the person sits directly on their sacrum, sits directly on their coccyx, and those ischial tuberosities really dig into the seat. And then the spine curves into that C curvature. The next abnormal posture of the pelvis is an anterior pelvic tilt. So instead of the dimples in the back being lower, the hip bones in the front are lower. And again, you see this very often in the nursing home setting with very obese patients, that they have a large gluteal shelf, which is what that excessive adipose tissue in the back is called. It pushes the pelvis forward, and then the person wants to lean backwards. They still try to make contact with their back with the back support, and you get that excessive lumbar lordosis. The next abnormal posture of the pelvis would be the pelvic obliquity that is linked to that scoliosis. So you can palpate it in two ways. You can either go behind and look for those dimples and palpate your two PSISs, or you can come through the front and palpate those two bones that jut out, your two ASISs, and you will try to see if one is lower than the other. And the side that is lower, that person will lean, and then their body will try to come to midline. So someone with an obliquity, you will then see a scoliosis of the spine. And then with the pelvic rotation, again, you're going to take both of the ASISs, and you're going to see if one of them is more forward than the other. So instead of being equal, one is more forward, and you know you're dealing with a pelvic rotation. And then obviously the pelvic spinal rotation will accompany that as well. And then, as I said, it's not just going to affect, the whole body alignment goes from the head all the way down to the ankles and the feet. So the pelvis is going to affect the spine is going to affect the pelvis, and it's definitely going to affect the head and the neck. And so a lot of times when we move into these different abnormal postures, you'll see someone's head a lot of times go into a lateral flexion. And what that means is that your ear is coming down close to your shoulder, kind of to listen to what your shoulder has to say. That is a lateral flexion. We do a lot of stretching with that, right? The second one, which is the most common, is that forward flexion, because it's usually accompanied with a kyphosis and a posterior pelvic tilt or sacral sitting. And so what happens is the patient goes down, their chin tucks into their chest, and their eye gaze goes down to their lap or to the floor. And this is really dangerous because it starts to have an impact on their respiration, their swallow, and even their socialization and interaction with their environment around them. The next one is that extension of the neck. And that happens a lot with that lumbar lordosis, the extensive, extension of the back where you have the lumbar lordosis happening, and the patient then looks up at the ceiling and they have an upward eye gaze. And even just doing that, that's not very comfortable. There's no way you're going to get a good swallow. There is no way that you're going to get a good breath if this is what your neck is ended up presenting with. And then the last one is that rotation. And this usually accompanies a rotation or even a scoliosis. And oftentimes you'll see a combination of like a lateral flexion, a forward flexion, and a rotation. So you'll start to see someone who their head starts to go down, it rotates, and it even goes to the side. And that just hurts my neck to do that like that. And you see a patient sitting in their wheelchair like this quite often. Okay, so putting them together. So I've told you what pelvis, what happens to the spine, what happens to the head and neck. And what I encourage you to do with this slide is print it out. Our therapists, have to do annual and quarterly screens in all of our facilities. And instead of just asking the questions, has your patient decreased in their ability to perform their ADLs? Has your patient decreased in their ability to ambulate? We need to start looking at other things because seating and positioning is one of those things. If it affects especially other health complications like pneumonias and bowel impactions and respiratory issues and swallowing issues, this is something that state surveyors are looking at. And so print this out, walk up and down your halls when you're doing the quarterly and annual screens, and look to see if your patients are presenting in this manner. And if they are, click them off for, to be picked up by therapy and accommodate for that or try to correct that with your equipment choices. Okay, so now you've kind of seen what is going on at the spine, why we should be changing out the sling back for a specialized back support so that you can either correct or accommodate for an abnormal posture. And that way we'll be able to increase the stability. That way we'll be able to increase the pressure redistribution so it's not just going through the pelvis, but we'll be able to put it through the pelvis, the legs, and the spine. And then lastly, by increasing stability and making sure this person is stabilized, you're going to be able to keep that alignment for hours on end and not allow that person to slide into an abnormal posture, not allow that person to fatigue as quickly so they can actually be up and interacting with their environment for the longest period of time safely. So let's look at the stability aspect first. So here is an example of what's happening when we are not using the specialized back support. So let's say we keep that sling back on or we use a tall reclined back, very straight back. So when we do something like that, and you're dealing with a person who has a very abnormal curvature, like, for example, let's go with the kyphosis. So here I have a person with a kyphosis, and I try putting them on a straight back. And the kyphosis will then only hit the back at the apex of the curvature. So the person is only making contact at one point. Well, it's not very easy to stabilize when you're teetering off of one point. We want to feel stabilized in our wheelchair system. You're dealing with patients that don't have balance, they don't have the best strength, and so they are looking for that strength and balance in their wheelchair system. So if they're only teetering off of one point, I assure you they will seek stability in another form. They will lean over to one side of the wheelchair into one armrest and create an obliquity and a scoliosis, or they'll slide down in their wheelchair and create more of a kyphosis and a sacral sit right on that sacrum, the coccyx, and the ischial tuberosities. They might rotate in their chair to kind of feel more tucked in and feel safe. But if we don't provide the stability, we give them a back support that makes them feel unstable and unbalanced, they will seek it out and they will slide into an abnormal posture. So now let's look at the same thing and look what happens when we do use a specialized back support that can add the stability. So we're using that same patient that has the apex of the curvature, and instead of now having a straight back, we actually can have a back that can be conformed to and envelop and wrap around that curvature. We are now making contact not only in one spot, but in 1, 2, 3, 4 spots. It's making contact with the entire spine. So now they feel stable, they feel supported, and they don't have the need to seek out the stability by sliding into a different posture. All right, moving on to the pressure redistribution aspect of a specialized back support. So the rule of thumb, if you want to prevent a pressure injury or you want to start to try to heal it, is you want to distribute the pressure over the greatest surface area. The greater the surface area, the smaller amount of pressure going into one small area. The smaller the surface area, the more pressure goes into that one area and really is like almost a dagger of pressure that will create a wound in that area. So we want to create the greatest contact that we can and create even pressure distribution. So again, with that straight back, we'll have one point of contact and all the pressure is going right here on this spinal column, and that's why a lot of times with a kyphotic patient, you'll see the spinous process be red on either side of that curvature and only there. So what we can do is as we start to envelop it and be able to capture that person's curvature, not only am I stabilizing more, but now as you can see in this picture, I'm having pressure enter along the entire spine, not just in one area like daggers of destruction, as I like to say. And then the last thing is, through that stability and being able to make sure that that person isn't sliding, you can keep that alignment for hours on end while that person is up in their wheelchair system without the risk of them going into a slide or a slump or a lean, and they'll be able to function at maximum capacity. So what needs to be considered? Now we understand what a specialized back support can do in order to increase stability, to increase pressure redistribution, and to help with that alignment. But what should I be thinking about? There's lots of choices out there, and I know it's overwhelming. So you definitely want to consider something called as the shape. Do I want a contour back versus a linear? And I'm hoping you're already leaning to something that I've alluded to many times. The linear is probably not the way to go. The medium, should I be looking for a foam back support, an air, or a combination? Adjustability, what should that back support be able to do in order for me to get the stability, in order for me to be able to create the even pressure distribution to maintain that alignment? And then lastly, how do I measure the person and then translate that into the size of the back support that I should purchase? Because we measure height, but then the back supports are sold in length. So sometimes it just doesn't click in our heads, and I'm going to show you how to do that. So the first thing is the shape of the shell. This is a tongue twister, the shape of the shell. Okay, so some questions that you should probably ask yourself in order to make sure you're going in the right direction with your back support is, what is the end user's end goal? Do they want to have more stability because they are someone who doesn't have the strength, they don't have the balance, they have someone else performing the ADLs for them, but we need to make sure that they don't slide down because they are very weak? Or is this someone who has better trunk control and they're very active? They perform their own ADLs. They propel all over the facility. Is this person's condition progressive? Because if it's progressive, they're going to change drastically from 1 year to the next. And you need a back support that can change with them so that you don't constantly have to be buying a new back support every time they have some type of change in their status. And then also, what is their postural abnormality? Because some back supports are better for certain kinds than others. Okay, so the shape of the shell. As I said, there's three main shapes of the shell, and this is dealing with hard shells. A hard shell is made from aluminum, or sometimes they have plywood in them, but they're hard so that you can actually mount the lateral to it or mount the head support to it. Extra accessories to really give you those final touches to really stabilize someone who needs a little bit more assistance. And the first kind is called a lateral contoured shell. And as you can see, it doesn't really have any contour in the posterior aspect. All of the contour comes on the lateral aspect, which is hence giving its name the lateral contoured shell. And we will look a closer look at its considerations and benefits in a second. The second shape that we're going to talk about is called a posterior open shell. This is a very new concept. It's been on the market for a couple of years now. Phenomenal. It is probably the most adjustable, and we'll take a look. So it has not only the lateral, where did my cursor go? It has not only the lateral contour, like the lateral contoured shell, but it also has the ability to be adjusted in the posterior aspect as well. And then the last shape that I wanted to talk about is that planar linear style. And this, just as you can see, it's just straight. It's a straight back that we've already talked about some of the things that are going to be wrong with it, so it has more considerations than it does benefits, but it's important for you to know what's out there and the considerations benefits of each. So the first shape, as I said, was that lateral contoured. The good thing about this shape is there's a lot of them. This has probably been the most advanced back support for the longest time in comparison to the linear. And so there's a lot of manufacturers making this style of back rest. And so what it does, it's actually designed to fit the anatomical shape of our user. So and I don't mean so much the posterior, but the lateral. So we are kind of rounded where our ribs are, and so it's meant to shape and really go around your rib cage quite nicely. The other thing is that it comes in a lot of variations when it talks about depth, so you can get something very deep. You can also get a difference in where the the laterals are. So this is more of a lateral that goes up and down the whole length, but sometimes you'll see a back support where the laterals are higher or the laterals are lower. That's going to hit more of the pelvis. This is going to hit more of the upper rib cage and the thoracic region. So it really just depends on where your patient needs the counter pressure to try to bring them back up the midline. Another thing is, now they've really come a long way, like I said, and they've thought about function for our patients. They don't just think about stabilization. They say, well, these people need to function as well. Thank God, right? And so one of the things that they look at is scapular cutout. So you definitely want to look for a back support that has a scapular cutout. And the reason they do that is because we don't want anything that's going to limit our scapula so that we can, raise it up, down, go forward, go backwards, so that we can perform our ADL, so that we can reach our wheels and propel. So you definitely want to look for a lateral contoured shell that has those scapular cutouts to allow that freedom of movement. So just like everything, there's some kind of consideration. That doesn't mean don't use it. It just means think about, is this the right back for my user? And one of the biggest things is that the contour is on the lateral aspect. It's not on the posterior shell. And if you think about a lot of those postural abnormalities, we're dealing with someone who has a posterior kyphosis, so it's jutting posteriorly. Or you're dealing with someone with a lordosis or a rotation. So it's going in more than just one plane. So this back support is really great for leaners, someone with a scoliosis, but may not be the best for someone who has a very significant kyphosis. Now, some lateral contoured back supports on the market do also have some type of posterior adjustability built in, and actually Kelly will show you one of these at the end in the product section. The other issue that you have to consider is that those laterals on the side are fixed. You're not able to move them up or down. And so you see it in the catalog, it might look great, but when you get it there, your person might be too tall or too short, and it's not going to actually hit them where you need. So maybe it's too high and it's going to hit them in the armpit region, and you might do some nerve damage or really just, start cutting into them. It might cause pain. Maybe it's too low, and it's just not hitting them where you need it to be. The only other thing that you should know is that all of these back supports, because they do have a hard shell, along with the fixed laterals, you can also mount a mounted lateral that you can then adjust up or down, but you cannot adjust what comes fixed on the back shell. Okay, the next back support shape is that open shell, and this is what I like to call, and you guys will notice very quickly when I have courses, I'm not a very serious person, but this is kind of like the Mac Daddy back support, okay? And the benefits of this back support are that it allows for excellent immersion posteriorly. So unlike the lateral contour, you can then accommodate for a kyphosis. You can accommodate for a lordosis. You can accommodate for a rotation and a scoliosis. So it's really going to conform to the shape of any end user. And what happens is, and you can see with this dotted line right here, it actually, most straight backs that don't have any posterior adjustability, the person sits in it and it pushes you back. But this back support, you immerse into it. So as they sit, it actually immerses the person in and it takes their shape. So it envelops their spine. And the way I think of that concept is, think of an Easter basket with all that fake fluffy grass, and it's kind of flat. And then when you put the egg inside, the egg sinks in and the grass wraps around it. And that's what this kind of back support does. As soon as you sit in it, it envelops you, it immerses you, and it wraps around your shape, whatever abnormal curvature you may have. And it really helps to bring the pelvis back into neutral as well. As well, it's very light for a self-propeller because of the fact, mainly, the whole entire back is cut out. It's wide open. So it allows for that immersion, and it makes it lighter, and you don't have as much risk of a repetitive strain injury because it's not as heavy as a back support. It can accommodate and correct for multiple postural abnormalities, like I just talked about. And then the two things that I love for the setting that we work in is that, number one, our facilities need, because we pay a lot for our own equipment, we need equipment that can go from one person to the next, that has a long shelf life, that can be used with multiple people. And so these type of back supports, you can adjust And then if the person expires and you need to put it on somebody else's wheelchair, you can completely reconfigure it, and so it can be used with anyone. The other thing that's really great is that if you have a patient with a progressive disease, you can change it from, let's say 6 months later, they look completely different. You just reconfigure it and make it now work for them. So it's just really great because as the person's status changes, you can change the back support, and you don't have to go spend a lot of money on replacing back supports as they get, worse. Some considerations are that someone with a very significant lordosis, it might be really more difficult to get into that low area, very, very close. But I can honestly say I have not seen that happen yet, but there is a chance of that. It has obviously a higher upfront cost. It's like I said, the Mac Daddy back support, it does so much because of all of it that it does. You're looking at something with a higher upfront cost. But I always go back to the last 2 points in the benefit section, and I said, but still, I may pay more up front, but I don't have to buy a new back support when someone gets worse, and I don't have to really buy a bunch of different kind of back supports because this one can pretty much do everything and can go from patient to patient to patient. Okay, and then the last back support shape is that plantar linear style. Benefits are it's very easy to use. It's flat. You don't have to worry about adjusting it. So someone who doesn't feel very comfortable with seating and positioning, it's a no-brainer. Just put it on and you let it go. However, that also means there's no adjustability to it for the patient. So kind of double-edged sword there. There's plenty of room to put mounted laterals, to put a head support because it is flat. So that's another great. Said, oh, foam, that doesn't sound good. That's hard. That's not good. It's going to compress really quickly. Awful. Foam is actually a wonderful medium if you're buying a great quality foam. So again, quality foam will allow for immersion. Again, let the person sink in, and then it will take the shape of the user. And it's very comfortable if you're using quality foam. A consideration is that innately it's hot. So you might actually be creating a microclimate. So you really got to be careful, what am I putting the person in? If I'm going to go put them, get them all in a polyester outfit, then yes, you probably are going to cause them to sweat like crazy. The other thing is that you have to consider the quality of the foam. If you're using a low-quality foam, then it is going to kind of compress more quickly under a lot of prolonged pressure. And like I just said, poor quality, it's not going to have a long shelf life. So just keep this in mind, guys. You can't go out and buy something that's great quality for $20, $40. Not going to happen. So that's one way to know probably is your foam more quality or not. The other thing is, is it a back support that you've used in the past and it hasn't lasted very long? A lot of times if you're just not sure about that, then you're just going to have to learn from trial and error. Okay, the next back support medium is air, and this is a phenomenal medium because the air cells really allow the transfer of the air, mimicking kind of like the quality of water. As that person shifts, the air is going to shift with it. So whatever's really jutting into the back support, the air is constantly going to be transferring, protecting that person, enveloping that bony prominence that's sticking into the back support to always give them maximum protection. Those air cells shift according to the shape of the user, and they allow for optimum envelopment. So just like water, when you put, a bony prominence against this, it's going to wrap around it. So it's not only going to protect the apex, but it's going to wrap itself around, envelop the bony prominence to protect all of the different the lateral, the front, all of the different sides. The other thing is it can be adjustable. Some manufacturers will actually allow you to take a quadrant of air from here. You can make it where there's no air cells here, so you can actually offload an area and take away pressure even more. A consideration of air, just like with the cushions, is it has to be maintained. The next thing is a combination. And when I say combination, I mean combination of foam and air. And so now you can really look at the benefits is that you have the foam that really adds structure to a back support. It really gives you that immersion and envelopment. And then at the bony prominences that are really at high risk, you have a strip of air that can really then take over and protect it even more. The consideration is, again, that it's hot where the foam is. You've got to make sure that you're using the correct foam, and the air might need to be maintained. Okay, moving on to what I consider probably one of the most important things to understand about a back support, and that's its adjustability. There's two types of adjustability that you should really, really understand and be looking for in your back support if you want to prevent those falls and those wounds and all the other health complications that arise with poor posture. And the first thing is you want a back support that can adjust seat to back angle. So remember and think back to that 90 degrees. Patients can't tolerate it, and a lot of them can't even get there. So we want a back support that actually can change that, because sometimes the fleet of wheelchairs that we have in our settings can't, right? So we can take the swing back off, put on a back support, and we've now changed a wheelchair that now can have seat to back angle adjustability. The second thing is, remember about the fact that we don't want to put them against something straight. We want to look for something that can contour to the and capture the exact shape of the user's spine. All right, so why is this important? Because we are not flat. Remember that our human skeleton, if you remember back to that ideal spine slide, we have that natural lumbar lordosis, the cervical lordosis. We have the natural kyphotic curvature of the thoracic area. We are not straight. And just like with the shoe, if you have a high arch, you want to support that arch so it doesn't collapse. It's the same thing with the back. You want to support those natural curvatures so they don't flatten out or they don't get excessively worse so that you're now dealing with an excessive kyphosis or an excessive lordosis. Another thing is we don't want to seat someone at 90 degrees. So that's why this is important. Remember, a lot of our patients, because of their limitations in hip range of motion, and we'll talk about why that arises in a second, they can't even get to 90 degrees. So why are we trying to force them? So we want to be able to have a back support that will allow the person to open seat to back angle instead of trying to force them at 90 degrees, which will then cause them to slide down, lean over, and increase the risk of falls. So with our elderly residents, this is why you don't really want to sit someone at 90 degrees. They probably can't tolerate it, and they probably can't get to it. And what happens is we're dealing with a population that is sitting in a chair for long periods of time or lying in bed for long periods of time. And when that happens, our muscles shorten. And so where those muscles are attached to, they will pull on the bony landmark that it's attached to. So, for example, here in this picture, let's talk about our hamstring muscle. This is one of the muscles that really shortens in a seated posture. And our hamstring muscle is attached to our ischial tuberosity, goes down the back of our leg, and attaches to our knee. So as that muscle shortens, it's going to pull on the pelvis into a posterior pelvic tilt. As well, and you can see that right here, it's going to pull it downwards. The other thing with the gluteal muscles, again, the gluteal muscles will shorten, and it's going to pull that pelvis down, which is why the posterior pelvic tilt is one of the most commonly seen abnormal postures. And then the same thing with abdomen. As those muscles shorten, they are going to pull us into more like a crunch position, and it's going to really collapse and cause our abdominal cavity, our chest cavity to collapse. We're going to have issues with respiration. We're going to have issues with digestion, issues with bowel and bladder impaction. And so you're going to see a huge, huge change in that person. And as it shortens, you're going to see someone come into a more of a kyphotic position. Again, why that's the most commonly seen in the nursing home setting. As well, we're also just dealing with the elderly patient that through the decades of life, with the natural progression of aging, we see the spine change. And you automatically see those curvatures get a little bit more curved at the thoracic cavity, flatten out at the lordosis of the lordosis of the lumbar and the cervical, flatten out, and you get more excessive at the thoracic cavity. And there's plenty of studies, and I know that today we can't even cough without having some study telling us that we've done it the right way. So there are plenty of studies out there, and it's interesting because they're not performing them on young, our geriatric population. They're actually performing these studies on young, healthy individuals. They're getting up, they're lengthening their muscles, they're shortening their muscles, and those studies are telling us that the young population can't even tolerate 90. They say that in order to keep their concentration and be able to perform their job tasks adequately, they don't want to be at 90. They want to have an open seat to back angle of about 100, 105 to 110 degrees. So if our young population can't even tolerate 90 to do their studies or job tasks well, why are we trying to force our geriatric population who has more need to have an open or closed seat to back angle? So how do we do that? How do we increase seat-to-back angle? Through the back support, and that answer is through its hardware. So right here in the middle, you can see hardware on a back support so that you can actually make the back support close or you can make the back support open. And you can see that with that picture here. It's kind of dynamic. In this picture, the hardware is set at 90. And then in this picture, you can see it has been opened. So now the back support is going into a recline position, into a posterior recline. And then over here, you can see that it's actually being brought into an anterior position. So you can open seat to back angle into a recline, or you can close seat to back angle. Most of our geriatric population, you probably have to open seat to back angle, but in some cases, you might need to close. But the point, and you do that a lot with patients with high tone, and they just feel like they need that stability. But the point is that through this hardware, you are able to actually match the seat to back angle to what the resident's actual need is. And that is what you should be trying to achieve in order to get that maximum contact with both the back and the seat surface, to allow that pelvis to come all the way back, and to take the pressure off the bony prominences and stabilize both the trunk and the pelvis to prevent the sliding in the wounds. So the second adjustability that you really want to look for in a back support is the ability to contour to somebody's spinal curvature. So here in this picture, it's going to give you a really great presentation of everything in adjustability that we just talked about. So in this first picture, we have someone set at 90 degrees. They can't tolerate it. They can't even get to it. So you see that their pelvis isn't all the way back in the chair because they can't tolerate it. So they are going to slide somewhere and open their own seat to back angle because you've tried to force them somewhere they can't tolerate. So they'll slide down in the chair and really open it themselves. And their legs will come up off the chair. Their pelvis won't be back in the pelvic well, and so that cushion can't do its job. The other thing is you'll start to see huge gaps in their back where they're not now making contact with the back support. So it's going to decrease the stability because, again, they're teetering off of one place, and it's also going to cause pressure to enter in one small area, placing that small area at a high risk for pressure injury. Now let's look at what happens when we open the seat to back angle. So again, we take the 90 and we open it up through the hardware of the back support. You are now creating that 100-degree angle that those hips can tolerate. So now you can get the hips all the way back in the chair. And the pressure is not only going through the pelvis, but also through their femur, which is what we want, pressure going through the femur and through the pelvis. And with the help of gravity, naturally, more contact is being made with the spine as well. So instead of one point of contact, we're now having a couple points of contact. And then let's take it one step further and not just open seat to back angle, that first adjustability we want, but also contour the second adjustability that we want. And now, instead of still having a straight back, we're taking someone and we're able to actually make the back curve to whatever spinal abnormality we're seeing. So if it's a kyphosis or scoliosis, you can actually conform to that specific person's spine. And now we have the hips back, all the pressure's going through the legs, the pelvis, and along the entire spine. So instead of having just a couple points or only 1 point, you're actually having pressure enter along the entire spine, which drastically reduces the risk of a pressure injury. You're also able to stabilize the entire spine, and so they won't be teetering. They're actually going to feel stable, and they won't shift seeking the stability from another part of the chair. They're going to be able to stay where they want so you can maintain the alignment for hours on end. Okay, so how do we conform and adjust the back supports for our residents? And one way is simply through the medium. And so you can either look at air or the foam, and they can immerse the person and they can envelop the spine. So one way to conform to a person's back is simply through the medium that you choose. A second way that's out there, another methodology, another technology, is something called moldable stays. And these are aluminum stays that you can see this one hasn't been manipulated yet, so it would be mimicking more of a straight back. Or you can change it in any way you want to kind of mimic the shape of that person's spine. So here, this would be mimicking someone with a kyphosis. This is someone who has more of a, lordosis and a kyphosis. So you're looking at something and your ability to shape these aluminum stays to capture that person's curvature, put them in the back support, and now you've just had posterior adjustability. Another way is through some type of tension adjustable system, whether it be Velcro or it be cables, but something that allows you to decrease tension in one area, increase tension in another area, get that back support closer and close those gaps so you make contact with the entire spine and you can adjust the tension where you need to in order to create even pressure distribution. But the big thing here with the adjustability and the ability to conform to someone's spine is you want to immerse that person. You want to capture their spine to create stability and to take away these gaps. So in this picture, you can see there's a lot of gaps, not making contact, pressure's going to go in one place, and with the ability to conform, you're taking away those gaps because now you've made contact with the entire spine. Okay, last topic is the sizing. So when you're going to measure someone for a back support, you have to consider, do I want a stability back or do I want a back that allows for more freedom of movement? So a more stability back is going to be a higher back. So the first thing you need to do is take that person out of their wheelchair. We never measure for anything while the person is seated in their wheelchair. You get them on a firm, flat surface, like a mat table, and you measure from the top of the mat table all the way up to the top of their shoulder. And the key is you get that person in the position you are striving for in their wheelchair system. Don't let that person slump down into the worst possible posture that they can do and then measure, because then what you're trying to do is this in the chair. Well, that means that you need a much longer back support. From here to here, there's quite a bit of difference in length. So make sure you put them in the position you're striving to achieve and then measure, which means you probably need another set of hands or two. The next thing is if you want someone who's a little bit more active, they need that freedom of movement, then you want a shorter back. You want to have freedom of movement of that scapula. So instead of measuring to the top of the shoulder, you're going to measure to the inferior border of the scapula. And some people actually even take away a half of an inch or an inch more and give you a lot more movement of that scapula. The next thing is, now that I've taken that measurement and I see how tall I need it to be, you see, the height, how do I translate that to the catalog to buy the product? And so we've taken our measurement, and so for this example, I'm going to want a taller back for stability. I put her on the mat table, I measured from the mat to the top of her shoulder, and I got 22 inches. But what I want is I don't want the back support to go all the way down to the seat cushion. I want the back support to end right at the PSIS, right at those dimples in the back, to really provide some extra stability to the pelvis as well. This is why a back support helps with pelvic alignment as well. And so what I need to do is we always start with the pelvis when we start purchasing our equipment. So you already probably have chosen your cushion and you know the thickness of the cushion that you want. So you take the measurement you got from number one and you subtract the thickness of the cushion. So in this example, I have a 3-inch cushion. So I measured her at 22. I subtract my 3-inch cushion. So I know I need to purchase a 19-inch length back support. Now, there is a hint for you. Most companies actually have even numbers in their back support. So if you need to have more stability, just round up to about 20 inches. If you want a little bit more freedom of movement, round down to 18, and you'll still be good to go. The next thing is, how do I figure out the width? Because just like cushions, when we need length times width, depth times width, in a back support, we need length times width. So in our facilities, we've showed you how to do the length. And then with our facilities, we usually have to use the fleet of chairs that we have. So the safest bet is whatever wheelchair their hips said that they needed to be in. So if you needed an 18 wide inch cushion and an 18 wide inch wheelchair, then the back will be 18 inches wide. If you're dealing with someone with more of a pear shape, then you might take the shoulder to shoulder width measurement and it'll bring it in for you. And most back supports that have hardware have some type of link system that you can actually order a smaller back because you can have links that will extend out to the back canes. So if you have a pear-shaped person, you can get a more narrow back support and a wider chair. So you'll have links that will actually extend from the back support hardware to the back canes. But for the most part, you'll probably just take whatever the width of your wheelchair is, and that will be the width of your back. The other issue that we have to think about is what do we do with a bariatric patient? And this is a little trickier because you have to do one more step when measuring for a back support. The first thing is the bariatric patient, remember we talked about that gluteal shelf, that excess of adipose tissue in the back. And what that does is that's the first thing to touch the back. So it pushes the person forward. So we don't want that. We want to take away for that excess adipose tissue. So what you do differently is you measure in step one and you get the size back that you want. And then you also have to measure step two, the height of their adipose tissue. So you need to go from the top of the mat table to the top of their adipose tissue. So in this example, I measured her from top of the mat to the top of her shoulder because I want a stability back, and I got 23 inches. But since I'm in the measuring mood, I also measured her adipose tissue, and I saw that it was 4 inches tall. I know the thickness of the cushion that I need is 3. So just like I did before, I subtract the 3 inches from the measurement I got in step one. So now I know that I need a 20 inch, but then I have to subtract the height of the adipose tissue. So now I subtract the 4 inches that I got from measurement 2, and I need a 16-inch length back. If I would not have taken into consideration her adipose tissue, I would have ordered her a 20-inch back, and it would have been way too long, and it would have pushed her forward because that adipose tissue would have been the first thing making contact with the back support. So we have to take that into consideration, subtract the height of that adipose tissue so we can still hit the patient at its PSISs. So you can see it's a much shorter back that we need to order with someone who is bariatric. Okay, the last thing I feel I have to talk about because I think they're really overused in the nursing home setting is the fact that we use too tall of back supports quite often. And when I say too high, I'm talking about those tall recline back chairs. They really are overused. They're very expensive, and they have none of that adjustability that you need. So number one, a lot of times we'll use the excess height as a headrest. You should never use a back support as a headrest. If someone needs a headrest, then get the appropriate length back support and then add a head support so it can really do well to support the head in the way that it needs to be supported. The taller the back without that adjustability, it's going to limit the scapular rotation, which is going to limit their ability to perform their ADLs and propel the chair. The straighter the back, as the person sits against it, it's going to push them forward. So it's going to give them the sensation of being pushed forward out of the chair. It's also going to make them fatigue faster, and you're going to start to see them collapse, okay? It also can't conform around the apex of the curvatures, and so you're going to start feeling more pain because pressure is going to enter right there at that apex. So again, please, let's not use tall recline back. Let's try to find back supports that can be adjusted to that person's curvature spine. Okay, so back supports can achieve a lot of things, and I'm not going to go through this because this is just a summary of everything we did, but the main thing I want you to understand is it's going to give you that maximum contact. It's going to allow you to have even pressure distribution. It's going to prevent the progression of an abnormal posture from getting worse. It's going to allow you to use the cushion in the intended purpose and really increase the effectiveness of the cushion as well. It's going to increase your sitting tolerance, and it's going to decrease those multiple health complications that arise from poor posture. And in your facilities, if you're really striving to have a lot of patients that look here on the left turn into patients that are looking more like the right side of the slide, then we have to remember the simple equation and understand that the back support plus the cushion plus the wheelchair model go hand in hand to make the stabilize the patient, to achieve good pressure distribution, to get us to that optimal seating system. So that will open it up and get us to the questions and answers session, and thank you so much.
What's an example of a back with moldable stays? Familiar with most of the other options, but not this one.
Okay, so moldable stays, actually in the product portion, you are going to see one. So we have, actually you'll see two. We have the Incrediback, which actually is more of a cheaper option, but is a great little back support for the long-term care setting. It can go and pretty much be used with a huge range of our population. And so it has a zipper at the top, and the moldable stays come out, and you can bend them to be, match whatever the curvature, the spinal curvature is, and put them back in. So the first one would be an Incrediback, and it actually has no hardware, so it's very easy to put on the chair. The second back support that I think you're going to see today is the ActiBack. So it is one of those lateral contoured shells, but it also has posterior adjustability as well through the moldable stays. So the ActiBack and the Incrediback are two great options.
Okay, and another question is, what is the best way to adjust the moldable aluminum in clinic?
But the best way to do that is you take the moldable stay out. Okay, so you unzipper the back that has it, take it out, and you put your hand between the person and the back support, okay? And you feel, and you have the moldable stay in your hand, and you feel where the curvature is. And you kind of, with the other hand, you make a spot of where you need to make it more concave or convex, take it out, bend it, and you bend it over your knee, you bend it over a table, you bend it on the door frame, put it back in, go to the next area that you need to kind of conform, and do it again until you get the curvature that you need. And then you'll know if you need to make it a little bit more intense, take it off, and you'll start to see that person come more upright. Hopefully that answered it, but I think you're going to see a video on that as well.
Two more questions. For the most flexibility and pressure relief, would you use the posterior open shell with air medium?
So the posterior open shell, there's really only one on the market right now, and the medium it has a foam on the front that really is added for comfort, but the whole back is open. So you're going to see it for sure with Kelly, and you're going to see that it immerses in. So that is the only one that's on there, but I can guarantee you it is unbelievable. You'll be very happy with that back.
And then do the back supports work on power wheelchairs also?
Yes. So depending on the manufacturer of the power wheelchair, it may only fit certain back supports. The manufacturer that I work for, we actually have what is called, and so you might want to take note of this, a power mount bracket. And so what it does is no matter if it's Quantum or a Permaville or, an Invacare, no matter what the power wheelchair model is, our Acta line of back, so the Acta Relief, the ActiBack, the Acta Embrace, can go on any of those wheelchair models. Other manufacturers of backs, like J-backs and those kind of things, sometimes they only work with certain models of wheelchair, which really limits their ability to be used. So the Comfort Company line does have a power mount bracket that can be mounted on any.
We are going to jump into Kelly's product portion.
Hi everyone, thank you for staying with me for just a few more minutes to look at some products here. As Robin mentioned, I'm a product consultant here at Direct Supply for our rehab category. Today we're going to be covering 3 products. Anna mentioned a few of them on her questionnaire there when she was answering her Q&As. The first one we're going to look at is the Incredibac, which she referred to as a great product for long-term care. It's real easy to attach. You remove the sling back and it slides right over those canes and then attaches. So it's quick and easy in that fashion. One of the things that they redesigned recently were the aluminum stays that are moldable. So before, you couldn't get to the aluminum stays. You'd have to go through a transfer with the resident, take the back and get those aluminum stays out, bend them in, and then get that resident back into the wheelchair. Now there's a zipper at the top here that allow for you to have access to those aluminum stays. So right in here, you can pull those out quite easily. You can do this right while the resident's seated in the chair, so it's nice and convenient, and it doesn't take as much time for you to really bend in and conform that to their back. The other thing to mention is that there's a couple options. So there's the standard, and then there's also a deep option with moldable laterals. Both are going to give you 450-pound weight capacity, and they're going to give you 30 degrees of recline option as well. So there's some great adjustability on here. Most importantly, though, that it's easy and it allows for some customization around the back. We're also going to show you today a product called the Actibac that Anna also mentioned. Now I have 2 models here. One is actually with the laterals and one without, so there's options within this line. Now how this differs a little bit from the Incredibac is that this is going to have a nice aluminum hard shell, so this is perfect for your heavy leaners, gives it a little bit more structure to the back, and then it has those moldable stays built in as well, and you can see those here through the patchwork here. Also has a zipper at the top so you can pull those aluminum stays out, bend and mold them, and configure them to the resident. I do like too that it has some hardware. The Compass 4 hardware here that we see is going to have a ton of adjustability for you, so it's going to allow for you to adjust the seat back angle, the height, the depth, the width of the seat, so really to accommodate that resident and ensure that they have the best fit for them. And then also, I wanted to talk quickly about the foam topper. On the Incredibac, you have foam as well. On this, though, you have a viscoelastic foam topper, so it's just going to have a little bit more immersion for you and added comfort. So great little product here that is going to accommodate, kyphosis, someone with kyphosis, rotation, scoliosis. So many different abnormal postures can be accounted for with a back such as this. And lastly, I wanted to touch on one that brought up some questions on the Q&A portion. This is the Active Relief from Comfort Company. This is going to be that open back that we were talking about, where we have the ability to really adjust through a system called BOA closure system. So the strapping here is going to allow for a deep immersion. And how I can't get my knee up on the table, much better demo if I was able to do that, but essentially just imagine someone's back being pushed into that back and then being able to lock that out so that it's specific to that person's curvature. So really accommodating the individual. And pull these out, that person immerses into the back here, and then we have the ability then to lock it in. So that's going to allow for real strong customization with this product. It also has that viscoelastic topper for foam as well, and it gives you that same hardware that allows for all that adjustability, which is going to be perfect for the resident that has some pretty significant postural issues. So 3 different options to choose from Direct Supply, manufactured by our partners over at the Comfort Company or Permobile I wanted to mention that any questions you have about the products or pricing, you can always reach out to your account manager. They can help you out with that and provide you a quote.
Thank you for your time, and have yourself a great day. Thank you.